Hi, my name is Leonie Campbell. I'm one of the PGY4 from Navy down the road, and I'll be presenting on herniated nucleus pulposa. We'll go over your standard anatomy, epidemiology, diagnosis, natural history, treatment, and then outcomes based on all the literature. So we'll start by discussing the anatomy. The intervertebral disc is superiorly and inferiorly contained by cartilaginous end plates, with the annulus making up the circumferential outer portion of the disc and the nucleus pulposa making up the inner portion. Often these are referred to as a jelly donut. Breaking down the annulus, it is primarily composed of type 1 collagen, which is laid out in concentric rings, and then elastin that reaches out radially from centrally. This provides the tensile properties of the annulus against compression of the disc with axial loading, flexion, and extension. The nucleus is the inner portion, which is mainly composed of type 2 collagen, which is high in elastin proteoglycans, as well as water. It acts as a shock absorber component for axial loading, and it transfers loads to the annulus and then the adjacent vertebrae. Either due to denervation or acute injury, patients present with back and radicular complaints, with the disc on the outermost portion of the annulus being what's innervated. These occur over time from degenerative standpoint as we age. There's a decrease in aggregate and water, which with increase in multiple factors, which include MMP, IL-6, PGE2, and TGF-alpha. Additionally, there's an increase in keratin sulfate. These are the same changes that occur with the cartilage throughout the rest of the body as well. We do not fully understand how to treat the etiology of pain that occurs, and this is an area of active research. However, we do know that these substances are areas that we can potentially target and are being used to identify areas of future treatment. Kind of the pathway as it exists. So as we all likely remember, the layout of the exiting and transiting nerve roots is important when working up the imaging studies in comparison to the symptoms that patients are experiencing. The exiting nerve roots are in the lumbar disc, in the lumbar vertebrae. The exiting nerve roots are affected in this example by the L4 disc herniation, whereas the transiting nerve root is affected by the paracentral disc herniation, which in this image is the L5. Again, so in this image, the L4 nerve root would be the exiting between the L4 and L5, and the L5 nerve root would be transiting between L4 and L5. So when we're discussing herniations, there's important nomenclature depending on the type of bulge versus herniation. So these abnormalities in the lumbar disc fall into two broad buckets: bulges and herniations. A bulge is greater than 25% increase in the circumference, which can either be symmetric or asymmetric, whereas a herniation is either a protrusion or an extrusion of the nucleus pulposa into or through the annulus. Looking at the imaging to the right here, the far left image demonstrates a symmetric bulge. Next to it, you have an asymmetric bulge. You can see how it's not centered versus a circumferential increase. And then you have herniations, either protrusion or extrusion, where the protrusion goes into the annulus but not necessarily all the way through it. And then extrusion is when you have an extrusion of the nucleus pulposa material out into the canal. And then if you look a little closer at these images, you can see how on the extrusion and protrusion, the yellow versus the red helps to define the extrusion versus protrusion, which is the base versus the actual density of the protrusion itself. The location of the herniation is also important, especially when we will discuss in a minute the effects it has on the symptomatology that patients present with. So looking at this image, you have the four sections. You have either central, subarticular, foraminal, or extraforaminal. And we'll go through each of these. So the central disc protrusion, you can see where the rim of the annulus is on the center portion, and it kind of just creates a small bulge into the central canal and it indents along the dura. These tend to create more of an axial back pain situation, not so much necessarily a symptomology that we can identify to a transiting or exiting nerve root. This slide demonstrates a subarticular herniation where it would be affecting the exiting L5 nerve root in this imaging, and possibly the transiting S1 as well due to the size of the herniation within this image. The foraminal disc herniation can also be appreciated on both the sagittal and the axial cuts, as seen in this imaging. On the sagittal cut, you can see that the foramen is not open and that there is disc material within the foramen, as well as the axial cuts demonstrating compression of the exiting nerve root. And finally, you have the extraforaminal disc herniation, which can be seen on the axial cut as well as the sagittal cut, more so on the axial, where you can see that's on the far component of the disc outside of the foramen. Moving on to cervical anatomy. So I pulled this slide in to make sure we all remember our illustrious ortho bullets, which I think has a great comparison of the lumbar spine versus the cervical spine and why it's important to know the differences. I always have to draw this out before the OID. So on the lumbar spine, you have a far lateral will affect the exiting versus the paracentral affects the transiting versus the cervical spine, regardless of where the disc herniation occurs, it's going to be affecting the same nerve root because the anatomy is more horizontal. So the important difference in cervical and lumbar herniation is the presentation and the effects on the spinal cord, particularly the changes within the cord that occur at the cervical spine versus in the lumbar spine, it's affecting the nerve root since the spine is ended, or the cord is ended at the L1 level. Particularly, cervical herniations can result in central cord compression resulting in myelopathy. And so this paper kind of went on to discuss these various types of herniations and how it relates to both myelopathy and radiculopathy with respects to where the disc herniations occur. Now, this is another paper that was looking at kind of how cervical spondylosis occurs and how it affects myelopathies, particularly that the longer the period of stenosis is associated with demyelination over time and ultimately necrosis. So we often talk about time periods in which we treat these things. And so this paper kind of like why we should look at treating the symptomatology that patients present with in the cervical spine, possibly a little earlier than those that we consider with lumbar. These two studies look at the incidence and epidemiology of cervical radiculopathy. The first study looked at a population-based to determine risk factors. It found that only 14.8% of cases had a preceding history of significant physical exertion or trauma, but the mean duration of symptoms prior to diagnosis was about 15 days, and the vast majority of individuals had C7 nerve root involvement, followed by C6. This was confirmed on MRI for about 21.9% of these patients, and they also found that 68.4% of these patients had spondylosis at the associated level. They had a recurrence rate of 31.7% after conservative treatment and resolution of their symptoms. Ultimately, 26% of their patients went on to require surgical intervention. In total, over the 4.9-year mean duration follow-up, 90% of the patients were asymptomatic or only mildly affected by the cervical radiculopathy. They found that males were more likely to be affected than females in the age group most affected, being 50 to 54 years. So that's in the first paper on the left from Rochester. What was interesting in the second paper, which was newer, which was using a military population as a representative American population, they had some significant findings that were different. Specifically, they found that instead of being in the 50 to 54 like the Rochester paper, their patients were on average in their 40s, most likely to be affected, as well as having a higher female versus male incidence, which is the opposite of their paper. It is possible that this population group study was affected by the fact that the majority of military personnel were younger versus the Rochester study. However, there were retirees and dependents included in this military group, which could offset the difference in the population. During the period of the study, it should be noted that both Operation Iraqi and Enduring Freedom were ongoing, during which there was a likely increase in incidence in cervical radiculopathy secondary to the change in protective equipment used by military personnel, which resulted in significant cervical degeneration. So I'm sure you've all read these guidelines, but they're going to come up numerous times in the rest of this talk. So I'm just going to hit a couple of high points real quick, but I do recommend that if you haven't read them recently, they're kind of a good review. But bottom line, friends, that 90% of disc herniations have symptomatic resolution in 6 to 12 months. And they strongly recommend careful selection and evaluation of those who require surgical intervention. So their three main takeaways were MRI is the imaging modality of choice, but not for acute symptoms. Most resolve in 6 months with conservative management, and absolute surgical indications include progressive pain and motor weakness. And this kind of keep in mind when you're looking at the following papers. So, or when we get to the following papers. So, epidemiological lumbar disc herniations, to dive a little further into these, they most commonly occur at the L4, L5 level, with the paramedian disc herniation affecting the lateral recess, which affects the traversing L5 nerve root for patients that present as a radiculopathy in the L5 distribution, and motor weakness affecting ankle and dorsiflexion and great toe extension. So this paper is primarily just looking at where do they most commonly occur from, and that was kind of the key takeaway is L4, L5. The North American Spine Guidelines previously referred to also some portions of their workup. And there's a few items of the workup that I think were important to take away. So one of those was for physical exam is that they recommend a supine straight leg raise versus a seated straight leg raise as being more sensitive and specific. For a patient with a history of physical exams are recommended first prior to for lumbar disc herniation prior to obtaining an MRI, and to make sure that you're getting MRI and lumbar disc herniation symptomatology should match. It did not have a strong recommendation for X-ray prior, though that's something that we do largely due to outside requirements. They also found that ESIs and RFA treatment recommendations vary based on location of the herniation and the type of herniation. And they do recommend evaluation for psychological distress and distress prior to surgical intervention, as worse outcomes after surgical management occur with those with higher or known incidences of mental health. Those with a positive straight leg test had more predictable improvement with discectomy, and the surgery should be reserved for those with severe progressive symptoms. They did not define severe progressive symptoms. They did not define severe symptoms. They did define progressive symptoms being like continued worsening. But the following papers that discuss kind of treatment, they often always just refer to severe symptoms, which is also a component of what the patient is experiencing, which leads it to be slightly subjective. Those with less severe symptoms medically versus surgically managed were effective, but for short and long treatment, but they didn't define, again, what that less severe was. So looking at the cervical versus lumbar examination, we talked about the importance of the straight leg test and the supine, not seated, and then looking at the positive predictive value of herniations with both paresthesias as well as the dorsiflexion at the ankle or tibia and the extension of the great toe. They often refer to the testing. They also discuss the cross straight leg test, or I'm not sure if I pronounced this word, but the Lasug sign, if I said that right. The contralateral leg having also a highly predictive value. So if you do the straight leg test on the opposite leg and they have pain from the ipsilateral side, radiculopathy on the ipsilateral side of the affected side, that can also be pretty strong positive predictive value to help with your confirmation of the severity of their symptoms. Again, this is discussing the straight leg versus the seated. And then going to imaging more specifically. So they looked at kind of what's recommended, not recommended. Always MRI is the right choice. Patients that cannot tolerate the MRI due to the duration of the test are appropriate for a CT myelogram. But if at all possible, MRI is the preferred choice. And then X-ray is primarily recommended for the C-spine if you're going to go to surgery to confirm that they're stable on flexion and extension. I've seen quite a few spec CTs on my couple weeks on service, and this actually was kind of cool to see that this was an update in 2021 on the spec CTs, and they're currently adding it as being used to help elicit additional information to identify other possible pain generators in the C and L spine, as this can affect treatment options. ACR only addresses this within the lumbar spine, but this can guide your treatment both in axial as well as radicular symptoms in the C spine as well. And currently, they're still working on it. And then we kind of discussed the imaging. Radiographs are good, as well as in the lumbar spine. So we talked about the C spine, but in the lumbar spine, they also recommend X-rays when you're going to surgery to, again, ensure that you're treating the primary modality. So if they have these great stable MRI images, but then you go to your FlexX imaging and they have spondylosis, then that's going to change your treatment plan. All right, so going on to treatment and outcomes. So they looked at the standard non-op farm therapy, physical therapy, and injections. So numerous studies kind of showed, and this is also reflected in the NAS, that a lot of these things, there's like a kind of, whether it's from time that people get better or whether it's a physical therapy, but the papers that they address are all with those with more severe symptoms. They're not looking at the general population that it's presenting with back pain. So they're looking at people with more severe symptoms. So with the more severe symptoms, the patients generally did not do well and did not have significant improvement with NSAIDs, corticosteroid, and anticonvulsants like gabapentin. And then again, this is kind of looking at the selective nerve root blocks versus physical therapy, and they had equivalent outcomes. This is a rather small study with only 44 patients, but it is present and showing that, again, those more severe symptoms don't necessarily improve. And if they do improve, it's a very short-term improvement. And this is looking at looking at steroid injections within the C-spine. They did have some like reasonable improvement within a short time period with those. Eventually, though, as time went on, having an increasing rate of going on to require surgery. And then men, again, in this paper, were more likely to eventually undergo surgery. And ultimately, at about the 5-year point, 20% of the patient had gone on to require surgery. So the thing that I found important when I was looking in each of these papers is actually what the symptomatology was. Were these like kind of more mild radicular symptoms that the patient could live with, or is these patients that in general already were saying these symptoms were severe, so it's affecting your study outcomes? This is another study looking at ESIs. They found, and this is also reflected in the guidelines, but for the transforaminal ESIs, those have the strongest recommendation and provided relief for about 50% of patients, but about a third of those still required surgery at the 1-year mark. And this paper kind of looks at that. Now we're talking about, hey, 80-90% of patients actually resolve on their own. And so they found the rate of spontaneous generation was about 96% of disc sequestration. So those are little free fragments that can move about, versus 70% for disc extrusion, 41% for disc protrusion, and 13% for disc bulging. I think when you think about the kind of going back to the earlier slides, the actual physical location and how those disc bulges are occurring, it makes sense. Those disc fragments can kind of move out of the way and are no longer necessarily putting pressure on the nerve roots as they exit. Those disc extrusions are still kind of pushing more, but they're a little bit more to the side and more flexible, if you will, and might also break off and become disc fragments over time. And then the disc protrusions have more of an annulus still containing them, which can become calcified. And then the disc bulge also has even more of the annulus, just the entire portion of the disc that's pushing out. So it makes sense when you think about the pathology of those different types, why you're going to have different resolutions over time. So kind of a summary of all the NASS guidelines for lumbar spine that we've gone over. It's a good document, but it definitely has to be like kind of picked through to determine what affects who, what, when, where, and why, and what treatments are recommended and what treatments are. Ultimately, a lot of them are kind of the in-betweeners, if you will. It's like not enough information was a lot of it, but you have a couple that are really good in terms of your workup, your physical exam, your MRI, and then who's likely to have good outcomes in the end. So kind of a summary of your non-op treatment options. It's common to use SPARM for herniations. It works for a decent 20 patients, but generally those with less severe symptoms that are likely to resolve on their own, and you're just helping them get through that first 6 months. There's not great evidence on physical therapy for cervical or lumbar. It's more of a time component than anything else versus specific physical therapy, especially when compared to steroid injections. And then the transforaminal ESIs were the most helpful for the lumbar herniations. And then ultimately, symptomatic relief over the course of the natural history is most likely why up to 80-90% of people, depending on cervical versus lumbar, have resolution. So moving on to why all of us are here. Surgical indications. So we have the absolute and relative, like many other things in orthopedics. Your absolute surgical indications have been like kind of previously mentioned, but progressive neurologic deficits and then severe pain that's causing global dysfunction. And then relative surgical indications are debilitating pain that lasts for greater than 6 weeks, which are not improving with conservative measures. So for surgical indications, we're talking about weakness. So weakness, 56%, 56 of these patients in the study had dorsiflexion weakening, which was measured at pre-op, 6 weeks, and 1 year post-op. The paper sought to qualify what level of symptoms would benefit from cervical intervention. We talked about the term severe is what's listed. They determined that in the first 6 weeks after surgery was their new baseline. So then they should continue out to 24 months after, but that first 6 weeks was what they were looking at. And again, the severe term is they were measuring it off of dorsiflexion and then extension of the great toe. This literature review looked at the progression of conservative management into surgical intervention to determine the best time point to intervene. They found that cervical radiculopathy and lumbar radiculopathy showed significant improvement in most patients over the first 4 weeks, with some taking up to 6 months to resolve symptoms with conservative management. However, they found that optimal intervention might be between 4 and 8 weeks for surgical intervention, but left this as an area of additional study. Currently, the NHS recommendation continues to be surgery within 6 months and 1 year, 6 months to 1 year, unless there was severe symptoms or progression dictating for earlier surgical intervention. And this was looking at a 10-year outcome of one of the sport trials. And I thought this chart was interesting. If you dig into it a little bit, you'll notice that Weinstein et al. Published two studies occurring simultaneously and were both published in 2006. One is observational and one is randomized. Sorry, it's not the biggest chart, but you can kind of see it here. In the observation study, the surgery group had better results than the non-op group. However, in the randomized trial, the surgery and non-op group had no difference in ultimate outcomes. Ultimately, this group of studies shows that surgery had better outcomes at 4 and 8 years versus non-op for symptomatic lumbar herniations. This paper I thought was interesting, especially for someone in the military, because our patient population is generally a little bit younger than the patient population I've seen here. But this is looking at return to activity in athletics, and I think it can also be, again, just helpful for that younger patient population that may or may not be participating in athletics, but is expecting to get back to like a very active lifestyle. And overall, 71% of these patients were able to return to play at about the 4.5-month point after injury, and notably about 96% of them were ultimately able to return to play at the same level or higher. Looking at more guidelines, and then this one is looking at the long-term outcomes of surgical and non-surgical in 10-year results. Again, 69% of these surgical patients and 61% reported improvement in the predominant symptoms. So we always ask the leg pain or back pain, which is worse. And this paper is looking at those with leg pain in particular. And then 71% of surgical patients and 56% of non-surgical patients were satisfied. So again, the surgical patients did better when they were appropriately indicated than the conservatively managed patient at the 10-year outline point, 10-year out point. This is looking at a similar study for cervical radiculopathy, and the last one was lumbar. And they looked at surgery versus a collar versus physical therapy. And then for them, this was not as broken out into severe symptoms. So when you look at that overall cohort of who needs surgery and who can do well with just non-op management, this paper is looking at that like, hey, a lot of people have similar outcomes that non-op, but it depends on your ability to indicate them appropriately. So the main points for surgery versus cervical treatment, again, cervical herniations, about 80% of patients will achieve complete symptomatic resolution without surgery at 4 to 6, and lumbar, about 90% of patients experience symptomatic improvement within 6 to 12 weeks. And so having your patient appropriately indicated is for the most important component for who gets surgery and who doesn't, and using your physical exam findings, i.e. leg raise for the lumbar spine, is super important. And that's kind of your summary data. Will you stop talking now?
Very nicely done. A lot of nuance in treating these, huh?
Yes, sir. I think my biggest takeaway was I think like everything in orthopedic surgery, if you don't properly indicate your patient, they're not going to be happy. So kind of teasing that out is super important.
Yeah. One of the things that you were talking about that I wanted to dive into a little bit is the type of herniations and why they behave differently. And it's not just the location. When you have extrusions versus when you have a contained herniation, it's not just about that the material can move out of the way. The extrusions actually can be more painful because there's a chemical nature to the aggravation of the nerves, not just a physical compressive component, but they also incite a resorption response. So they, as you pointed out, they resorb more reliably. So it's just they behave differently, I think, a little bit more because of the nature of the body's response versus the ability for that material to change locations or be in different positions.
Thank you, sir, for the clarification.
Question for the group.
Yeah.
We were in a clinic the other day, and a rep from one of the kind of like the company's called Barricade. They use like an implant that kind of lodges into the disc space dorsally to prevent reherniation. How many people are doing that? What's been your experience with that? Do you find that to be useful?
Well, I mean, you have to look at the data for that. The data is pretty compelling for large.
Yeah.
Carnegie from Stanford did one of the big landmark studies on that issue, and His study represented that herniations with large defects, and it's sort of arbitrary, but more than 6 millimeters in size were high risk re-herniating conditions. So like 30% versus several percent. So a huge difference. And so that's the target for that device when you have a larger defect. And then the data, there's multiple studies that have been done and good randomized trials. It's somewhere around a 60 to 80% reduction.
Yeah. So
in re-herniation risk rate in that particular subgroup. It's probably something good to consider.
I thought about putting like a little slide on that in here, because I've heard you guys talking about it, but yeah, we'll get to it. And it's kind of
It's barricades. I mean, it's not a new concept. There's dozens of patents, tried suturing. I mean, there's a bunch of different products and attempts at trying to close those defects over the decades, but the biology of the annulus is not great or not predictable. And so most of this have met with failure. And there's also a mechanical challenge, right? You got huge, when you swing a golf club, you can generate 700 PSI, and it's an enormous amount of force. And unless you get biologic healing, it's unlikely that a device that is just in the tissue is going to be able to restrain that or resist it. So it wasn't until this thing where it's basically planted to the bone. And even with those, there's reports of re-herniations around it. So it's not perfect.
Almost like the annulus, like as a whole, is compromised, and then you have to fix one part, it can just
right.
the other part.
Yeah, I'll send you guys the information on the guy. But
the bigger challenge with herniations, in my opinion, is it's the heterogeneity of presentation, not just in the type of herniation, but the patients, their coping mechanisms, their subjective ratings of pain.
Mm-hmm.
You have to fill through that. And I also think there's even a difference at level. Like a patient that's got a 4 or 5 herniation tends to be much more resilient and physically capable than one at 2, 3. You lose your quad and you can't walk without, actually serious injury. That's a different animal. Yeah. You have to treat that a little differently in terms of threshold to operate versus my foot's a little floppy.
Yeah. And most of the papers were all on like the 4 or 5 level.
Yeah.
But they also did have one, actually some I breezed over it, but talking about like the fact that you lose like your capillaries kind of end growing at 3 years of age to provide it's like totally vascular up to that point. And just like the genetic component. I did not appreciate the genetics to my own personal trail down C-spine stuff, which is like how genetic it all is. And it's like,
Oh, it's quite.
that's not like anything I can do about it.
No, I know. It's a frustration.
also are using like any topical steroid at the time of decompression or anything else doing that. So
Not anymore. There was at least one study that showed a higher infection rate with that. So tried it. Didn't meet with great.
It's like on the indeterminate and the NAS guidelines.
Yeah.
Speaking of infection, if you use a barricade, hypothetically, and the patient ends up with a post-op infection, you have to take that out. The one, if it's like,
It's a good question. We don't know,
yeah,
but probably.
probably
In the
a
end.
nightmare.
Yeah, seriously.
Oh, about them.
And you can only do this at 4, 5, and 5.1. So it's the common levels. But you have to get enough room to get that thing in. Maybe be in sub 3/4, but it's really intended for the lower levels.
Hey, Bob, I have a question for you since I haven't done one yet. What do you think the extra exposure is required to place the device?
Really not much. So, yeah, I mean, I think for if you do tubular, you're doing a 12 or 14 millimeter tube to do these microdiscs, and you're very minimalistic, and you're just kind of lifting the ligamentum up and trying to sneak by the nerve root and doing what we'll call limited fragmentectomy. That's a situation where you're probably exposing more than you otherwise would. The way that most of us do it here, it's not any different.
Although it is hard, like I try to place them through an 18 millimeter tube, and it is kind of hard because it occupies like 75% of your working line of sight. So they are coming out with a smaller inserter and a smaller device. I think that'll be nice.
And a retraction mechanism, so you actually just can affirmatively retract without worrying about it. Not having to see so well.
Yeah, because you're fixing this in the inferior body, right? So S1 or L5.
Oh, either end plate, whatever is accessible. Yeah,
Okay, got it.
you have your choice.
All right.
So it's a good point for you guys. One of the things that you can run into with doing microdisc is conjoined nerve roots, which is hard to just do technically. That would be a bad situation for that kind of a device.
Yeah.
It's challenging to even get in there safely for a microdisc, but that's something to be, aware of when you're actually doing the case, and not to push too hard. It's like this